Okay, well, thank you very much, Chris, for the opportunity to speak. Now, this is a plumbing talk, and so we're not going to be dealing with meta-analyses or level 1 evidence, but rather, I guess, just some practical issues related to ureteric obstruction and the management of that, particularly in the context of either the risk of or its association with or cause of acute kidney injury. And I guess just to begin with, obviously diagnosis of ureteric obstruction is a key issue, and it's perhaps not quite as straightforward as one would imagine. We generally associate hydronephrosis, which refers to dilatation of the pelvic seal system, as a feature of obstruction. But there are several important caveats to this to be aware of. And firstly, that obstruction, or specifically acute obstruction, particularly high-grade obstruction, can occur without dilatation or only with minimal levels of dilatation, and also that dilatation of the pelvic seal system may not necessarily reflect obstruction. And these two ultrasound images don't show particularly well, but this patient on the right here, in fact, just had a congenital megaureter. There was no obstruction, whereas this patient here had a high-grade ureteric obstruction related to a small distal ureteric calculus. And so the take-home message is that obstruction may be suggested by hydronephrosis, but not necessarily diagnosed. The other issue is that the severity of dilatation actually doesn't relate necessarily to the severity of obstruction. And interestingly, gross hydronephrosis is generally a hallmark of chronic or partial obstruction that's been there for a significant period of time. Acute obstruction, however, relates to only mild or modest degrees of dilatation. This relates to the hemodynamic effects that occur in response to the obstruction, and that very quickly renal blood flow is affected and urine output from the obstructed moiety ceases relatively quickly. And so rather than chronic obstruction producing gradual passive distension of the collecting system, non-functional, poor function, the kidney quickly supervenes, and that may limit the degree of dilatation. So again, the message is the degree of dilatation does not correlate with the severity of obstruction. And again, just two further ultrasound. The one on the right is a patient who's got an acute obstruction related to a calculus at the pelvic-ureteric junction, whereas this patient here actually has a chronic pelvic-ureteric junction obstruction with massive dilatation and thinning of the parenchyma. Whilst ultrasound is very helpful, and certainly in most departments will be the initial tool if potential obstruction is suspected, the CT scan is the primary imaging modality that is practical in the emergency setting, notwithstanding the concerns with respect to contrast exposure and potential risks. Now, not only is it necessary for a CT scan, but it's important that the radiologist is clearly aware of what you're trying to establish, and that a very specific request in relation to the nature of the CT. And in fact, it's a 3-component study where it's important that pre-contrast scans are undertaken, and this is mainly to establish the presence of calculi and a baseline for evaluating enhancement, which can be used as other tools to assist in the diagnosis of some form of acute process occurring to the kidney. And again, this is a CT scan which just illustrates this point. It would look as though the kidney on the right has got dilatation with contrast in dilated calyces. The left kidney, however, appears relatively normal. But in fact, when you look at the pre-contrast scan, you can see that what looks like contrast in the collecting system is in fact a large number of calculi. And so therefore, if a pre-contrast scan is occluded, an important cause of ureteric obstruction may be overlooked or missed, and therefore the appropriate management may not be instituted if this component of the scan is omitted. The later phases of the scan are, I guess, an early phase after the injection of contrast, and this is essentially assessing corticomedullary perfusion and assesses perfusion of the kidney. A later phase, which can occur from 3 minutes to often many hours later, can be undertaken to assess the presence of late perfusion of a kidney that did not appear initially perfused, and also to evaluate excretion from the renal unit. In addition to the presence of dilatation, the other features that one is wanting to ascertain from the CT are secondary features of acute obstruction that are often just as helpful in the clinical management, and these are the presence of diffuse parenchymal swelling of an obstructed kidney, reduction in perfusion of the kidney, particularly the early arterial phase, delayed or reduced excretion from the renal unit, and also the presence of what is called extravasation around a kidney. Now I'll just walk through each of these particular features. Again, not always well understood by radiologists, and so therefore people in the acute setting need to be aware of this because it may be overlooked by the registrar, particularly at a junior level, in reporting an acute CT scan. Now this scan here just illustrates the first point, and in fact, as I'll lead into later, extravasation from the renal collecting system. But here you can see this sort of swollen kidney compared to the contralateral kidney, and then this sort of blurring of planes in the perinephric fat. And so this kidney has got an acute degree of obstruction, even though if you look at the collecting system here, there appears to be very modest dilatation of the collecting system and certainly no calyceal dilatation. The second component is a reduction in renal perfusion. And again, if it's reliant on a single scan, there is a differential diagnosis other than obstruction, and this can include renal vascular pathology rather than arterial stenosis, probably arterial thrombosis, or in the trauma setting, an intimal flap that's resulted in loss of perfusion of the kidney. Venous thrombosis can also occur, which can again result in this parenchymal swelling and edema around the kidney. Similarly, acute pyelonephritis can also give a similar appearance with reduction in both perfusion and also function of the kidney. And then mechanical obstruction, which we're principally dealing with as an acute problem. And again, this just shows this relatively normal looking kidney, but with markedly reduced perfusion and no evidence of early excretion, and yet in the pelvis I've got this small ureteric calculus. And so again, just illustrating hydronephrosis is not necessarily a feature that will exclude or diagnose obstruction. With the later phase of the scan, you can see this kidney, there are two factors. The left kidney here, essentially is all the contrast has been flushed through, the collecting system is still seen. This kidney, however, the kidney still appears very bright, and so it's got delayed perfusion, this hold up of the contrast within the kidney, and then this dilatation and also layering of contrast, which again is a feature of delayed excretion into the collecting system. And finally, dealing with ureteric extravasation, and this shows an old-fashioned IVP, which I don't think we use at all now, but just illustrating how this sort of appearance with this extravasation of contrast is seen, and you get phone from the emergency department to say someone's ruptured their kidney, there's all this dye, but in fact it's really just related to the tenuous connection between the actual calyx and the parenchymal part of the kidney, and just a rapid rise in pressure within the collecting system just results in disruption of that connection, and then contrast coming away at this junction between the calyx and the papillae, and this then just leaks around and surrounds the kidney and will persist. But in fact, it in itself is not a major issue, but just a reflection of an acute high-grade obstruction. And again, this is just that initial scan that we saw, and you can see here all this sort of blurring of the planes is just urine that's actually extravasated and now creating this edematous appearance within the perinephric fat. I guess once someone's sort of looked at ureteric obstruction, then it's obviously important to try and ascertain what the cause is, because that is obviously going to help direct the acute management. And just in simplistic terms, we can think of this as either supravesical, where it occurs in the proximal urinary tract, where it's uretrovesical, that is at the junction between the ureter and bladder, and then infravesical, so something below the bladder neck. And so if we're looking at various components that can cause supravesical obstruction, This can either be luminal, so something within the lumen of the ureter, and typically a calculus is the obvious example, or a slough papillae is another example, both of which can cause acute ureteric obstruction. Most other forms of supravesical obstruction are chronic in nature and can relate to stricture formation, the presence of a tumour, as can extrinsic compression, also from a retroperitoneal tumour or lymphadenopathy, and also retroperitoneal fibrosis. The only acute obstruction occurring that's extrinsic is surgical injury, where a ureter has been ligated, usually in the pelvis in the course of gynecological or colorectal surgery, given its proximity to other structures that they are planning to ligate. Obstruction at the level of the ureterovesical junction can be related to a calculus, and this is typically the point at which small calculi will become impacted. And so there'll often be a very small calculus in the distal ureter that may not be easily seen on a plain radiograph, and also often difficult for radiologists to actually pick out from a phlebotomist without the appropriate imaging being performed. Bladder tumours can also cause obstruction at this level, but again this tends to be chronic in nature and very rarely associated with any acute presentation. Infravesical obstruction, this is often bilateral, so bladder outlet obstruction related to prostatic disease or urethral stricture, and these patients can occasionally present with significant degrees of chronic renal failure, but again it's only when they reach end stage that they may present, so they're again rarely a cause of acute ureteric obstruction. With bilateral obstruction, this is usually chronic, although rarely patients can have calculus disease, which for various reasons can present simultaneously, and again with surgical injury on occasions this can present with bilateral acute ureteric obstruction, which can actually have a very dramatic presentation in their early postoperative course, usually about day 2-3 before it comes to notice, when people see this progressive rise in creatinine that's refractory to usual hydration and other measures. I guess going on to sort of the key point, and that is the issue of ureteric obstruction in the context of acute kidney injury. This can occur in some two settings. One is the acute obstruction of a solitary or dominant renal unit, and this would be less common than the more usual presentation, which is someone which can either be due to acute obstruction or even chronic obstruction, which has become complicated by infection. And so AKI and ureteric obstruction is usually in the clinical context of sepsis, and that the management of the patient is therefore a combination of managing their septic process and its consequences, but also intervention to reverse the effects of obstruction and the deterioration of the patient. And in fact, acute kidney injury in association with ureteric obstruction and sepsis is actually a urological emergency, and it's underpinned by two key elements of management, and that is antibiotic therapy. The patient, by its very nature, by the nature of obstruction, will often progress rapidly to a bacteremia and septicemia, and so therefore they are systemically unwell and have systemic infection. Importantly, though, the relief of obstruction is a key element, and a common fault or mistake is that patients will often undergo a period of temporary stabilisation with administration of antibiotics, but in fact that will be temporary, and the patient ultimately will not get better until relief of obstruction. Similarly, the relief of obstruction is an emergency, and that there are cases where patients have actually undergone antibiotic therapy and then delayed drainage of the kidney with a subsequent demise. And you may have heard a urologist in Bradford went to jail for manslaughter because of delay in use of a nephrostomy for drainage in a young woman who appeared to substantially respond to antibiotic therapy and then very rapidly demised subsequently. And so the point is that don't be, I guess, lulled into a sense of security by the patient apparently approving for a period of time, because often the subsequent deterioration is then very, very difficult to manage if the patient hasn't had relief of their obstruction. The decompression of the obstructed system is the key element rather than necessarily definitive management of what's caused the obstruction. Obviously, if it's someone with infravesical obstruction, then catheterization, often the nature of the obstruction, such as stricture formation, may require a suprapubic catheter being inserted. Generally, however, acute kidney injury and ureteric obstruction relates to unilateral obstruction, and in this case, a stent or nephrostomy is required. Now, this creates a lot of discussion as to which one the patient should get. And I guess all of you who've tried to deal with ureteric obstruction will often be confused by the answer you're given if you ring the radiologist or the urologist as to which one is the best. Usually the other one to the specialty that you've just rung. But I'll discuss that in a minute. But just very briefly, just explain that a nephrostomy is an interventional radiological procedure, usually done under image intensifier or ultrasound control. The image intensifier may be useful if the patient's had contrast with delayed obstruction and contrast is still present within the collecting system. There's a target that the radiologist can use. More commonly now, ultrasound is used, and in this technique, it's a simple Seldinger technique that's common in all areas of medicine, where basically the collecting system is punctured, a guide wire inserted, and then a catheter placed over the guide wire and positioned within the collecting system. Stents are, I guess, internally inserted, so do require an operative procedure with a cystoscope through which the ureteric orifice is identified, and again a similar principle with insertion of a guide wire into the ureter beyond the obstruction, and then placement of an internal diversion with a stent with pigtail ends in the collecting system and in the bladder, which then allows relief of obstruction. It's not actually drainage through the tube, but in fact a capillary action where most of the urine actually drains on the surface of the stent rather than actually the inside. And so it's actually not the size of the stent that often helps with the drainage, but rather just the presence of a foreign body. And in fact, if you just inserted a wire in the ureter and left it up in the renal pelvis, that would actually relieve the obstruction. And urologically, when you're placing a wire, you'll see this sort of sudden rush out the ureteric orifice, and all you've done is actually pass the wire beyond the level of obstruction, but it just allows a mechanism for urine flow to occur. Now, the big debate, stent versus nephrostomy. Now, the key thing to remember is actually it's decompression of the renal unit. That's the important thing, rather than exactly how it's done. And I think in reality that there's no correct answer, and largely it's a balance of the resources that you may have within your hospital at that particular time, the timing and practicality. So if all the interventional radiology suites are obviously busy doing some complex vascular or neurosurgical procedure, then obviously it may be far better to embark on a urological procedure. There are, however, a number of patient and medical condition factors that may dictate one of these over the other, but by and large the principal decision relates to resources which are available and the timing and practicality. And so a stent tonight is better than a nephrostomy tomorrow in someone who is unwell. And so it's important not to get too hung up, although you will phone people and they'll give you complex reasons why it needs to be this. But the key point is decompression, because that's the key component of that patient improving. As I mentioned, the resources, obviously not everywhere that has a patient presenting with acute ureteric obstruction will have interventional radiology or interventional radiology services that are practical after hours. And similarly, urology requires a theatre and a general anaesthetic, and so there's staff beyond just the person undertaking the procedure that are involved. And so they're the resource issues that one has to balance, and that may be more or less practical to get one of those compared to the other. The stent, and again this is a personal bias, is obviously done in an operating theatre with an anaesthetist, and often for the extremely unwell patient this may be safer than someone who is somewhat unmonitored and unchecked in radiology, who is lying prone with the radiologist focusing entirely on the procedure. So in essence, the patient who may be significantly unwell will have an anaesthetist assisting with their physiological management during the procedure. The downside is that there are situations, and again surgical injury or ligation is an example, where primary failure of the insertion of the stent may occur, and this is in the presence of complete obstruction. And so if very high grade or complete obstruction is present, there may be a stronger case to go to a nephrostomy rather than a stent. But in the vast majority of cases, I think the extremely unwell patient may be better managed in a controlled environment, which is an operating theatre more than the after-hours interventional radiology suite, which by and large is less well equipped to manage the extremely unwell patient. The other potential problem with stenting is that where malignant obstruction is present, adequate drainage may not occur, and this relates to infiltration of the ureter, its inability to peristalse, and therefore the capillary action is not as effective as it is in the benign situation where the ureter essentially has normal physiology. With thick inspissated pus, the stent may also inadequately drain, but again this can be problematic with a nephrostomy as well, so it is just a situation to bear in mind, I guess, more if the patient doesn't improve with insertion of a stent or nephrostomy, that in fact drainage may not be adequate. As I mentioned, the nephrostomy is done in an interventional radiology suite. All interventional radiologists would actually regard this as pretty low fruit in terms of the technical difficulty compared to many of the other procedures they would do. Unfortunately, the procedure is often done under a local anaesthetic and the patient in a prone and somewhat unmonitored situation, which is the issue that if the patient is extremely unwell and a nephrostomy is required, having another medical practitioner there monitoring the patient may be important, because people do die in interventional radiology suites in the course of nephrostomy insertion, and it's often because of a protracted, difficult procedure in which no, I guess, specific measures have been undertaken for further resuscitation of the patient. Nephrostomy is obviously somewhat more invasive and can be associated with a number of risks, and these in the acute setting, particularly the septic patient, may be coagulopathic, can be bleeding, and this can result in significant perinephric bleeding and hematuria. It, as a long-term consequence, can lead to arteriovenous malformations in a similar fashion to a renal biopsy. So basically in the course of the procedure, an artery and a vein are punctured together, communication established, and this can be a late sequelae, can present months later with a large false aneurysm within the parenchyma. Similarly, a segmental artery may be injured with the insertion of the nephrostomy. It's often very difficult, and the radiologist may not be able to correctly align the nephrostomy where he would in an elective setting, say as a preliminary to a percutaneous nephrolithotomy, and so segmental infarction of the kidney, and in rare instances loss of the kidney has occurred as a consequence of injury with nephrostomy insertion. Nephrostomy does have limitations with a coagulopathy, as I mentioned, which may be difficult to correct in the acute setting. Similarly with the non-dilated collecting system, again, very experienced interventional radiologists don't see this as a major challenge, but it can be a potential limitation, particularly in someone who may not be doing this on a regular basis. And there are various anatomical deformities. Morbid obesity is one, but patients with scoliosis, spina bifida, these sorts of disorders can often be very difficult to position to allow safe insertion of a nephrostomy tube in the emergency setting. So I guess with that sort of preliminary, I'll just now run through a number of clinical scenarios more as illustrative points to, I guess, follow on from that. And one of the common ones that we urologists get called is someone who's come in acutely unwell, they've had a nephrostomy inserted, back in intensive care, not travelling too well, and it's noted that not a lot of fluid is coming out of the nephrostomy tube. Now this just may reflect the injury to the kidney, but obstruction needs to be considered, and again simple flushing in the ICU setting is often the initial first move, and then obviously a nephrostogram to check the position has been adequate. These things can occasionally migrate, particularly those done in an emergency setting. And importantly, if the patient does have unrelieved obstruction but had a nephrostomy inserted, this needs to be dealt with again relatively acutely, because in this setting a perinephric collection or abscess may evolve if the nephrostomy isn't replaced or a ureteric stent inserted to relieve the obstruction, because they'll have an obstructed distal, their ureter will be obstructed, and they'll have now a conduit for extravasation to occur because of the puncture through the collecting system and renal parenchyma. Another scenario, not particularly common, is emphysematous pyelonephritis, and classically this is seen in diabetics who develop obstruction, usually in the context of long-standing urinary infection and calculus disease. And this just illustrates the patient with gas in their collecting system, but also gas going into the kidney. And so they actually have this gas-forming organism with invasion into the renal parenchyma with complete non-function of the kidney. Now, there are obviously grades of this, and this isn't to be confused with, I guess, rather than pyelonephritis, I'd refer this to as emphysematous pyelitis. And so the urine here is infected with a gas-forming organism. This can be E. coli under certain circumstances. And the point here is that the parenchyma is not involved, and so therefore the management of these two scenarios can be quite different, recognising that this can quite rapidly evolve to this tissue invasive gas-forming infection. And I guess this is a critical illness. Patients can present, and often these are diabetics, and so they can be just not right, a bit obtunded before any septic cascade with the profound sort of hemodynamic effects of that. With emphysematous pyelonephritis, where it involves the renal parenchyma, I'd accept stenting or nephrostomy with extreme caution. And again, the mortality from an emphysematous pyelonephritis can be significantly more than people imagine. Where success is reported, it's generally in the context of gas within the collecting system and not within the renal parenchyma. Certainly stenting and nephrostomy can be undertaken, but in the seriously unwell patient, I think nephrectomy should be considered at a very early stage because of the high mortality with leaving this as an ongoing septic focus. Papillary necrosis is another condition causing ureteric obstruction. This is a transplant patient, but it can arise as a consequence of some other acute disease process. And so patients, particularly if they're sort of diabetic, got vascular compromise, can develop essentially infarction of papillae, which can then slough and cause acute ureteric obstruction. So it may not be the primary presentation of their acute illness, but be one of the things that can unfold in their longer term care. And again, it needs to be dealt with as with all other forms of obstruction. The other situation that often occurs, despite having said that obstruction must be dealt with as an emergency procedure, is that the patient, despite relief obstruction, can go through an initial period of quite marked clinical deterioration. And this probably reflects a bacteremia that's induced by manipulation of the infected kidney and collecting system, and largely reflects an endotoxemia. The hemodynamic effects of sepsis are actually the endotoxins rather than the bacteria per se. One of the, I guess, issues that this can often reflect is inadequate antibiotic dosing, where the patient is dosed with essentially sort of bacteriostatic levels as a preliminary to a manipulation. And this is actually a relatively common scenario in acute management of acute kidney injury, where smallish dose of antibiotics are used, and I guess gentamicin is the one. Now, to some extent this may be partially historical, but this was for many, many years the sort of antibiotic of choice, certainly amongst urologists, in managing urosepsis. And it has, I guess, two phases of action. At a lower dose or concentration, it's bacteriostatic, and this is by binding to bacterial ribosomes, which is an irreversible effect. And because of the irreversible binding, the effect actually will persist for long after plasma clearance. But again, this is sort of a bacteriostatic effect, whereas with much higher concentrations, gentamicin also has a bactericidal effect, and this is related to its effect on the biofilm and also the bacterial cell membrane. And so essentially it is very rapidly sort of lethal when used in high concentrations. And again, this is just showing, I'm sure we've all seen this before, that the effect relates to two factors, and one is the sort of peak concentration for this bactericidal effect, and then its bacteriostatic effect reflects the area under the curve, and so the total exposure to the drug as well as the peak level, which has a very sort of rapid effect due to the high concentration. And again, the key point is that it's better to give very high doses infrequently, remembering that the bacteriostatic effect will persist for longer, even when levels have dropped well down below the MIC. And this is just illustrating, and this is a rather old slide, the effect of sort of daily dosing with exactly the same dose split into 3 in the course of a day, and with this the renal cortical concentration, which is actually the prime mechanism of nephrotoxicity with gentamicin, is much greater using the same dose, but rather it would be better used at a very high dose but infrequently. And so again, I stand perhaps corrected by my nephrological colleagues, but my preference would be to use a very large dose at the time of initial presentation, particularly before any sort of manipulation, with then use of trough level monitoring, essentially with a view to potentially redosing at a more modest dose. But the message is sort of one very big dose initially can often overcome some of the cascade that occurs after the actual procedure. So I guess just looking at the sort of clinical scenarios in terms of imaging diagnosis, we're obviously dealing with ureteric obstruction, and based on history and symptoms, there is the clinically obvious, someone who's a known calculus and hydronephrosis. More complex imaging may not be required, but in someone in whom there is a degree of suspicion and uncertain diagnosis, I would use generally contrast enhanced CT scanning with the protocol mentioned. And that when someone has acute kidney injury, drainage really underpins the management. The choice of drainage is resource and clinical scenario dependent, and the important message is that if it's associated with sepsis, it's an emergency intervention in conjunction with adequate antibiotic dosing.